Hi everyone, this is Neil Wright, consultant audiologist and director of ClearWax. Thank you for joining me in another demonstration video of our soon to be launched WAXscope. And in this particular case, we have a patient who attended with bilateral, fully occluding earwax. This is the patient's left ear we're commencing with. And you may have noticed just at the bottom of the wax plugs, this inferiorly, there is an indentation. And that indentation into the wax itself, we're going to zoom in a moment, or should I say focus in on a moment, there we are. And I'm going to try and remove this wax plug by entering this indentation. So this is where the patient themselves have been poking and prodding inside their ears with a cotton bud. And what it's done, it's really lodged this wax plug deep into the ear. So I just used the Zollner suction probe there to perform microsuction to just work away at that particular point. And now I've installed some medical grade olive oil spray just to change the consistency of the wax plug, just to give it, allow me to get a bit more of a grip. The surface is quite dry, and just by introducing some oil, it softens the surface and then allows me to get a good suction grip. So we're starting to work away at this plug. You can see there's a few hairs within the wax plug. Now, one of the interesting findings that I've been able to detect and realize by using the WAXscope is just how much hairs, loose hairs, are inside the wax plug itself. With the endoscope, it doesn't really give you that same magnification into the plug of wax itself, but I'm just outstanded by how much hairs are within the wax itself. So that was the main plug, just some residual wax there that separated as I was removing the plug. There's going to be some dead skin just anteriorly, but I'm just going to look at the eardrum first. Just going to get it in focus. So we are actively working on an autofocus feature with the WAXscope, where instead of manually having to adjust the focus, you can just double tap the screen, and it works pretty well. It's not going to work 100% of the time, but it's an additional feature that may become useful, and you can always override it with the manual adjustment of the focus. When you're removing wax using the WAXscope or a microscope or a head-worn microscope or loupes, you do have to adjust the focus. Now, in terms of an ENT microscope, for example, you would just do that by bringing forwards and backwards the microscope. They normally have a little handle where you can hold on to do that. And with the head-worn versions, you just move your head backwards and forwards. It took me a while to get used to doing that, truth be told, when I was using head loupes before. And with the WAXscope, it's similar. You do have to adjust the focus. So with the WAXscope, you can either go forwards and backwards with the WAXscope, which is held in your hand, so the speculum goes forwards and backwards. I much prefer to get the speculum more in a stable position that really kind of stabilizes the view and also the procedure, and then adjust the focus manually on the app itself, or as I said, you can use the autofocus. So there's different ways of doing it. So some dead keratin at the roof of the ear canal, just peeling that away. So this patient did report some psoriasis or itchiness of the ear. So this may be one of the reasons, alongside, of course, the main wax plug. And I'm slowly just peeling that away. So the speculum actually is outside of the ear now. To the right, you've got the first bend, and beyond that, the second bend. So that's the second bend there to the left. And again, you've got a little sheet of dead skin at the roof, just going to peel that away. Using the fine end suction probe now, because the majority of the wax the wax plug itself has been removed, and the patient can hear significantly better. You then simply revert to the fine end to reduce the suction noise, and also to limit any clarinetting. Clarinetting is when dead skin violently flaps as you attempt to suction, and it can be really noisy. So that's the patient's eardrum again. And just how clear the view is there. See all the blood vessels, capillaries at the roof of the eardrum. So same patient, this is their right ear. So I'm just going to dilate the ear canal. So I'm using the 4.25 millimeter speculi here. We've got 4 sizes in total. The smallest size is 3.5 mil, and that's the internal diameter. The wall thickness of the speculum is 0.6 mil. So when you add that on both sides, that would be 1.2 mil. Add that to the 3.5, so it's actually a 4.7 mil diameter. So for the 4.25 mil internal diameter, the external diameter will be 5.45 millimeter, which is around probably the average width of the ear canal. Now, it's true when people attend with wax, they generally, most people who present with wax, not all, but most, have kind of narrower than probably the normal sized ear canal. Hence why they're getting the wax builder, so the wax is finding it a bit more difficult to migrate. So that's where the 3.5 millimeter specular really comes in handy. I had a I think I uploaded the video a few days ago of a patient with almost a virtually collapsed ear canal. And with 3.5 millimeter specular, we were able to really get that into the canal, to the cartilage portion, the outer third, and retract it and stretch it and dilate it. So there's a bit of a skill actually. It's been a while since I first performed microsuction. We're using a specular so as with anything, when you're reintroducing yourself back to a particular skill and you're used to doing it in a different method, it just takes a bit of muscle memory really. It all comes back very quickly. So again, we're making good headway with this right ear. I did put some olive oil spray in there. We've got the majority of the wax. You can just see the top of the eardrum at 1 o'clock there, but just going to get this wax plug in focus here. There's going to be some residual wax left over. You'll see at the end. We tried to remove it with the fine end, but then we're getting some clarinetting with the skin. It's non-significant. It wasn't going to cause much of a problem, so we just left that. We just don't want to expose the patient to unnecessary clarinetting. I'm just elevating stuff to the back canal wall. So once more, this has been impacted. The patient had been poking aside. So just stretching the ear open. So the tip of the speculi is just beyond the second bend. And beyond that, the ear canal converts from being made up of cartilage to bone, and the bony part is a lot more sensitive. So obviously with the bony part of the ear canal, you're not able to stretch or dilate that. You can only do that with the outer third of the ear, the cartilaginous portion. So we've got the majority of the wax. So I'm just going in. I'm going to straighten the ear now. You can see how we're now looking at the front of the ear canal. This is some wax there. And that vacuum nicely. Okay, just got some. I'm going to have a look at the eardrum now. You can just see the details. So a bit of reflection. So I'm just going to turn the exposure down, the brightness. That's the hammer bone, the malleus. And you've got some residual wax there. So of course it looks humongous with the WAXscope in particular because of the magnification. So just going to get it in focus. So now the speculum is being directed to the floor of the ear canal and also the back of the ear canal, the posterior canal wall. Just hovering over. So this wax is combined with dead skin. Now on the back part. So this is the border of the bony part, the cartilaginous portion. And quite often you can tell that by the complexion of the skin just changes slightly. Tend to find the skin and the bony part is just a bit more pink, and that's because the blood vessels are more exposed. Because on the bony part you've only got the epidermis layer of skin, the outer layer of skin, which is less than 0.1 or 0.2 millimeters, whereas the cartilaginous portion, the skin's a lot thicker, it's about 1 millimeter in thickness, and you've got the 3 layers, the epidermis, the dermis, and the subcutaneous layer. So you can see that skin here. So as yet, it's not clarinetting, but I think in a moment it does, and we just leave it. It's not going to... there's no point risking any clarinetting just to remove some surface wax. I think that was the point. I may have left it. I'm just going to mop up near the entrance there, I believe. Or perhaps not. I think we're done there. So I'm just going to look at the eardrum again, get it in focus. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. And if you are interested in the WAXscope, please email info@clearwax.co.uk. Thank you, bye.